Good evening, everybody. Good morning for someone. So, thank you very much for joining us today to attend our first webinar for Lipedema Awareness Month. I'm here with Sherry Fetzer, and we would like you to know that, as you are aware or might be aware of, there are still a lot of points of concern in lipedema. And we, as patient association, would like to contribute to the diffusion of best practice in lipedema management. And so we have decided to get together and advocate for proper treatment and proper information, and through this webinar series. So we are the three associations. It's me for LIO Lipedema Italia, Lipedema UK, and andLINFA from Portugal. And we three are bringing together our effort to organize this joint web event series for Lipedema Awareness Month that are intended to be live streamed worldwide in different languages through our social media channels. So it's LIO Lipedema Italia is represented by me, that is Valeria Giordano and Marcella Oggiano, Sherry Fetzer and Kate Foster on behalf of Lipedema UK, and Manuela Lorenzo Marques. Did I say it well, Manuela? Please say me that. From andLINFA. So thanks for having us today. Well, let's get right into the event, but before, allow me to thank you, our wonderful donators who made all of this possible. So thank you to Human Med, to Uso, Cizeta Medicali, Solidea, and Medi UK. So now let's move forward. We have to present our special guest tonight. Tonight we are going to know what's going on in lipedema and be informed about research updates. So let me introduce you a person that actually in the lipedema world doesn't need any presentation. So Dr. Karen Herbst, thank you for being here with us today. Dr. Karen Herbst is one of the most remarkable voices in the international lipedema research and treatment. She's been working with women with lipedema for over 15 years and has many publications on lipedema and other connective tissue disorders. So she's passionate about finding new treatments for lipedema towards a real cure. She's currently the medical and research director of Total Lipedema Care. And now I'll hand over to Sherry. Thank you very much. Sherry, to you.
Thank you. Thank you very much for the introduction, Valeria. I'd like to particularly introduce Dr. Thomas Wright, who is another American, and we're very, very grateful to make this an international event. So thank you very much, Karen and Thomas, for joining us today, because we really want this to be a participation of all people from all areas. Dr. Wright has published 6 peer-reviewed manuscripts on lipedema and related fat tissue disorders. He's worked with Dr. Karen Herbst on the first ever recently published guidelines in the US, the US Standard of Care Guidelines for Lipedema, which really is a major step forward. And thank you very much for all the work you both put into that. Dr. Wright is also collaborating with the Washington University School of Medicine and the Lipedema Foundation. Again, really, really important forward-thinking work. And the study there is going on to better understand lipedema tissue, resistance to weight loss, which is something we all struggle with and know only too well, and a better understanding of the biology of lipedema, which again is so necessary. I mean, every patient is craving this information and waiting to see what you find. And Dr. Wright is very passionate about bringing attention to this disease. So we are internationally very grateful for all your efforts. I just mentioned that all of our webinars will be recorded, so they'll be available to watch again on our various websites, and we welcome everybody sharing them as much as possible on other websites and social media. Our aim is to learn from the very best worldwide, and it's wonderful to kick off with you two, such reputable and wonderful people. Thank you very much.
Thank you.
So, Valerie, what's our next stage?
I think that we can give the word to who is starting, Dr. Herbst or Dr. Wright? Who of you?
I think I'll go ahead and start. That's okay.
Okay, so we're almost listening to Dr. Herbst. And do you have the slides for Dr. Herbst, please? Okay, so I will leave you, Dr. Herbst. It's yours.
Okay. Can you see my screen?
Yes.
Great. Okay, so thank you so much for the invitation to speak from both of you, but also from andLINFA as well. And Tom and I decided that we wanted to talk about new research in the area of lipedema, and I'm going to focus on inflammation to start. Here's my disclosures. So lipedema is an inflammatory disease, and I will prove that to you in a few minutes, but I just want to start with this statement. And the reason is because I want to begin to try and understand the inflammation process. So here is a cartoon of what inflammation looks like. And inflammation starts with something, some sort of infection or an injury. And the immune cells recognize the infection or the injury, and they start secreting things. They secrete messages to bring in other cells from the immune system. They actually try to kill infections if they can find it. And they may also try and to reduce the damage in the tissue. And the first cells that encounter an injury or an infection are mast cells or neutrophils. And then from there, if the inflammation resolves, then macrophages come in, and macrophages come in and clean up the mess. So they're going to pick up all of the debris, and they're going to return it to the body, and it will be degraded and then reused. And then the body enters what's called adapted homeostasis. So it goes back to what it should normally be doing. Homeostasis means just normal functioning in the body. However, there's this concept that in the weeks to years after the inflammation completely resolves, that the tissue that has been damaged or injured is predisposed to develop chronic inflammation again. And some of you might think of examples of this. So if you get sick and you have an old knee injury that's doing just fine, when you get sick, you start to feel pain in your knee again. So there's some kind of memory within tissue, and part of this memory may be in immune cells. And one type of immune cell is called a T cell. And these T cells can be memory cells. So they remember that there was an infection, which is really important. If they see the infection again, your immune system immediately responds and gets rid of the infection faster than in the past. But could it be that there are some memory cells within our tissue that can remember the presence of inflammation, including that of lipedema? Now, if the inflammation does not resolve, then the body enters what's called maladapted homeostasis, where you have chronic inflammation, autoimmunity, and also fibrosis. And it could be in lipedema that there are areas with adapted homeostasis and maladapted homeostasis. So I mentioned that there was inflammation in lipedema tissue. Yes. So there are 2 studies that have looked at the immune cells in lipedema tissue. In the first study, they showed that there are increased number of white blood cells, and this marker CD45 plus is a marker of just general white blood cells, and they were elevated in lipedema tissue compared to controls. And then they also looked at macrophages, which were elevated compared to controls. So could it be that in lipedema tissue, we're in just a chronic maladaptive resolution phase of inflammation? In the second study, they looked at women with lipedema who had obesity, so body mass index greater than 30, or not obesity with a body mass index less than 30. And you can see In the lipedema tissue, it doesn't matter whether you have obesity or not, there are increased macrophages in the tissue. So something is definitely going on related to inflammation. And I'm sure you all remember this study when it came out, platelet factor 4. So platelet factor 4 is a marker of inflammation. It's very well known as a marker of inflammation of the gut. And you can see that in controls, there are not very high levels of platelet factor 4. But in secondary lymphedema, lymphovascular disease, and lipedema, the platelet factor 4 levels were higher, suggestive of inflammation. So the question is, are platelet factor 4 levels higher in women with lipedema because they have obesity? And the answer is no. You can see down here that in controls that did not have obesity and controls that had obesity, platelet factor 4 levels were normal. You have to have some kind of lymphatic disorder to see elevated platelet factor 4 levels, at least in this study. So a second marker of inflammation. And here's a third one. So this is a study that just came out this year, a couple of weeks ago, and they looked at a marker called CD11C. And this is a marker suggesting if it's high, that there's more immune cell infiltration. And you can see they looked at controls, the abdomen or the thigh in patients who had lipedema, and immune cells were much higher in the thigh compared to controls. What I think is interesting is it was also elevated in the abdomen compared to controls, but it did not reach significance. But maybe with a few more women in the study, it would have. And finally, we know that if you have inflammation, that your body is trying to resolve it, and it tries to fill it in with scar tissue. So if you look at control tissue here, compared to lipedema tissue, you see a lot more pink in the lipedema tissue. That means there's fibrosis or scar. And they quantitated it over here on the right. There are lower amounts of fibrotic tissue in controls compared to women who have lipedema. So you've got the whole process going on. You've got inflammation, resolution of inflammation, and fibrosis. So what is causing the inflammation in lipedema? Could it be injury? Could it be infection? So I'm going to talk about how fluid enters tissue to prepare for the next part of the talk. So the heart pumps blood through the arteries, arterioles, down into the capillary, where the capillary has holes in it that allows fluid and nutrients to enter the tissue. Right after the capillary, there's a small vessel called the postcapillary venule. And the postcapillary venule is part of the vein system that returns blood back to the heart. But the postcapillary venule is very responsive to the environment, especially to metabolic mediators and things that come out of immune cells like histamine, for example. So if you have a lot of histamine in your body, it's going to act here to increase the amount of fluid that enters the tissue. The fluid that enters the tissue is all picked up by the lymphatic vessels, which return that fluid back to the veins, and everything is recycled. So here's a happy little cell down here. It's got plenty of oxygen. It has just enough fluid and food around it. So it's got normal oxygen. We call that normoxia. But here's a very sad cell. It has way too much fluid around it, and it's not able to get access to its oxygen. And we call that hypoxia. And with COVID going on now, I think we all know the term hypoxia. So these cells send out a signal, help. And that signal is HIF1 alpha. And that stands for hypoxia inducible factor 1 alpha. And when you have that factor around, secreted by cells that are in trouble, you get more blood vessels and more lymph vessels, because your body wants to get oxygen to those cells and it wants to remove the excess fluid. You get more immune cells, so you get inflammation, and you get increased adipose tissue. And that's very much so sounds like lipedema. So is there a problem with the small vessels in lipedema? So in this study, they looked at how dilated the small vessels are. And if you make vessels really fast, you don't make them very well, and they tend to be dilated and leaky. And sure enough, when they looked at vessels from women who had lipedema or controls, there were more dilated vessels in the ladies who had lipedema than the controls. So check, we've got that. And this is an old study showing a capillary vessel here, and inside it is a circle, are the red blood cells. And you can see outside here is fluid. So this capillary, excuse me, is leaking fluid into the tissue. And if you look at the walls of the capillary, they're thick. Capillary walls are super thin. They are only 1 cell thick. And you can see they're thickened here, suggestive of inflammation. So again, something's wrong with the capillary. And that post-capillary venule that I told you about that responds to metabolic mediators like histamine, you can see that it's very dilated. So it's probably pouring fluid into the tissue as well. And we wanted to look at this further and not just look at one patient. So we looked at 21 patients who had lipedema and 21 that did not. And we did biopsies of the skin because you can see a lot about the body in the skin. And you can see here's a blood vessel with a star on it, a white star. And then here's an extension of that vessel. It's a white star as well. And you can see the space around those vessels. That space is fluid. So these vessels are leaky. And what does the body do when there's leakiness in the tissue? It sends an immune cell. So you can see all these black dots are increased immune cells in the tissue. And finally, you can see these round cells here. These are endothelial cells that have become round. And that's not good because if they're round, they've actually opened up a whole area where fluid and other parts of the blood can just leak directly into the tissue. And that's actually shown over here, more leaky vessels in women who had lipedema compared to controls. And these are age-matched and BMI-matched controls, so they're very well matched. So this is, again, a study that just came out, and I'll walk you through it. It's a little complicated, but I promise you, you'll get it. So what they did is they took liposuction tissue, and they digested it up, and they got rid of all the fat cells. So any mature fat cells is gone. What's left is a mix of stem cells, fibroblasts, immune cells, endothelial cells, any cell that you could think of that's going to be in fat tissue. And then what they did out of those cells was they pulled out the endothelial cells. So these are the cells that make blood vessels. And then he put them into a culture dish, and they said, okay, grow. And the endothelial cells grow up, and cells like each other. So endothelial cells grow towards each other, and they form what's called tight junctions. And that's shown in red. And the endothelial cells are shown in blue. Then they taught, then they used artificial intelligence through a computer program and said, hey, computer, we want you to recognize what a good tight junction is. So when endothelial cells bond together, is that a really good bond or is it not? And what they anticipated was there may not be good bonds in lipedema. So they said, if it's not a good bond, it's more like lipedema. If it is a good bond, it's more like control. And they did a lot of this testing in order to generate that artificial intelligence program. And you can see here that the artificial intelligence program on the top three, which are all control endothelial cells, says, yeah, it's more likely to be a control in all three cases. And when you look at the bottom, which are endothelial cells from patients who had lipedema, you can see that the artificial intelligence said, hey, this is more likely to be leaky, so therefore it's more likely to be lipedema. Okay, so from this we can say, yeah, it looks like lipedema tissue is more likely to be leaky than control. So then what's interesting is they asked the question, well, why is it leaky? So they took that stromal vascular fraction, which is, again, just the cells left over after they digest fat tissue and get rid of mature fat cells. Then they took normal human endothelial cells that you can buy from a company, and they grew them up in a culture dish. And when you grow up these cells, you cover them with a liquid, and that liquid is chock full of nutrients. And they let the human endothelial cells grow. And then they took the stromal vascular fraction and they added it from control cells, and that's the top panel, or from lipedema cells, and that's the bottom panel. So the same type of human endothelial cells are growing, but the top panel has fluid from control cells. The bottom panel has fluid from lipedema cells. And here's the machine learning. It says in the top panel, very likely that these are very good tight junctions, again shown in red, with the endothelial cells shown in blue. Whereas on the bottom, which is your lipedema fluid, it shows that very high percentage chance that these are leaky vessels. So the message from this study is that there's something that's being secreted by the lipedema tissue cells that is causing that microvessel leakiness. So now we're on to something. And this data all supports data from the 70s and 80s showing dilation of blood capillaries under the skin, immune cells around blood vessels, fibrosis of arterioles, and fibrosis and dilation of the venules. So this is not new, but I think it's really strong evidence that we're on the right track to figuring out lipedema. So if we look at the inflammation process again, we've got leaky blood vessels, and we have to figure out what's causing the leak. So what is in that fluid that's being secreted by the lipedema tissue? So I made a list here. It's definitely not inclusive. So there's things that I'm missing from this list, but these are all mediators that can cause leakage from endothelial cells. And some of these things that you're going to recognize, like histamine from mast cells, or thrombin involved in clotting, or substance P involved in pain. That's very interesting. Or sphingosine 1-phosphate, which is secreted often by parasites. So if the parasites, which are cells that hold the vessel shape, they can either make it smaller or larger. If those are damaged, then of course you're going to have leakiness of vessels and a whole bunch of other things. So it maybe what is important in lipedema pathophysiology is on this list. Maybe it's not. Another thing I just want to point out on this list is that the extracellular matrix can actually cause leakiness. So maybe damage to the extracellular matrix is releasing things causing vessel leakiness, and then that damage in the extracellular matrix is where things start. So it could, why does lipedema get worse in some women than others? So maybe underlying all of lipedema are these leaky vessels, but there are other things that can contribute. For example, could the small vessels actually be weak and then they get the signal to be leaky and then all heck breaks loose? So we know that many women with lipedema have hypermobile joints or hypermobile connective tissue. And you say, but if you look at a capillary, it's only an endothelial cell. It's not connective tissue. Well, this is a picture of an endothelial cell, and you can see the little holes in it where nutrients, oxygen, and fluid enter the tissue. But around it is connective tissue. So that endothelial cell is just not sitting there flapping in the breeze on its own. It's held in place by connective tissue fibers. And so connective tissue fibers outside the cell are connected to connective tissue fibers inside the cell. So cells themselves have connective tissue in them. So even a capillary can be involved in a connective tissue disease. So why does lipedema happen on the lower part of the body? Well, when you stand, fluid in your trunk drops down into your hips, thighs, buttocks, and lower legs. And that increases the pressure within the vessels. So if you have a vessel that's already weak and you increase pressure in it, it may leak more. Then you add on that some sort of secreted product that's also causing more leak. And so there may be multiple reasons why there's just this chronic leakage from small vessels into the tissue, and why it more often affects the lower body than the upper body. So we've got weak capillaries and associated connective tissue, and even weak postcapillary venules. We've got inflammation, so something that's being secreted. And in addition, I'm just going to add in there may be venous hypertension, venous insufficiency, so high pressure within the veins that's causing that post-capillary venule to leak. All this leads to increased lower body pressure in the vessels, and that equals lipedema. So here's our inflammation process again, and I wanted to just state again. So in the weeks to years after complete resolution, the tissue is predisposed to developing chronic inflammation, and this suggests the presence of tissue immune alterations or memory cells. So some kind of memory cell in our tissue that may be present when lipedema first occurs in the body. So could memory cells be important in lipedema pathophysiology? So I want to introduce this concept of microchimerism. So when a woman is pregnant, she transfers immune cells and stem cells to her child. So it crosses the placenta during pregnancy. And if she breastfeeds that child, she can also transfer T cells to the child in that way. So as an adult, 1 out of every 5,000 of your T cells came from your mother. So again, the question I ask is, why do some women get worse lipedema than other women? Could it be that if a woman had lipedema early on in her life and it was rather severe, and then she had a child, could she have passed on to her child these T cells, which are memory cells of her lipedema? So in some cases, could memory cells induced by lipedema in mothers pass to their daughters? And this certainly doesn't hold for women who have lipedema who do not have, they don't have any children, but it's in other members of their family, and they don't know where it comes from. But it also doesn't align with women who say it came through their father. But could it have any influence at all on lipedema? So with this new knowledge, what's the treatment? So I think it's important to identify lipedema early and treat to prevent inflammation. If we can treat to prevent inflammation early, we not only improve quality of life, but we may also inhibit the generation of those memory cells. And then women won't be able to pass those memory cells down to their daughters, if that is indeed a true mechanism important in lipedema. And I would love to hear from all of you. This is certainly just a concept I'm throwing out there, and I think it's really all for discussion. We don't have any proof. And I think it's really important, if you have lipedema or you have a patient with lipedema, that you need to reduce known sources of inflammation. And they're all around us, as you know, some which are very difficult to avoid, like unhealthy buildings that you work in. You get on public transportation, someone's wearing perfume that you're allergic to, any kind of environmental toxin in your toothpaste, your lotion that you put on your body, your shampoo, what you wash your dishes with. Things that you can control in part are insulin resistance, so prediabetes, and that is to keep your non-lipedema obesity down as low as possible. And you do this through eating the right food, exercising, supplements, working with your healthcare providers. Sleep apnea can cause inflammation, liver disease, surgery can cause inflammation, any kind of trauma, including emotional trauma. Depression can increase inflammation in the body. Eating inflammatory food, definitely get your veins checked out to see if they have inflammation. Autoimmune thyroid disease, which is common in lipedema, can be a source of inflammation. Allergies, mast cell activation disease, PCOS, and inflammation in the gut. So testing for metabolic disease includes a hemoglobin A1C, which is often normal in women who have lipedema. So I like to check a fasting insulin and glucose level, and then I calculate what's called the Homa Index. And you could just look this up online. There's a bunch of Homa calculators, and it's basically fasting insulin times fasting glucose all over 22.5. And a value of 1 is normal. Anything above 1 suggests insulin resistance. Anything above 2 is concerning. You can also do an oral glucose tolerance test with your healthcare provider. Check a lipid panel, so your healthcare provider would be able to help you interpret that. Check your waist size, your blood pressure, your liver function and enzymes. And if I see any fat on the abdomen in my patients with lipedema, I like to look at a right upper quadrant ultrasound. That's just looking at the right upper part of the abdomen, and we check for fatty liver. And the reason for that is the liver produces 25 to 50% of the lymph that flows through the thoracic ducts. So it can produce half of all the lymph fluid in your body. If you have anything like fatty liver, fibrosis, cirrhosis, this increases the amount of fluid that's being generated by the liver. So definitely important to work on getting your liver fat down to normal. And when you get that right upper quadrant ultrasound to identify fatty liver, you can move on to get what's called a non-contrast MRI, and that will actually quantitate the amount of fat in the liver. This is most often done in research. It's actually rather expensive, but it can definitely, if you have a lot of fat in the liver, it may be a good idea because it can also identify fibrosis. This is a study that came out last year saying lipedema can be treated non-surgically, a report of 5 cases. And Dr. Amato et al. Used an anti-inflammatory diet or alone or followed by a low-carb diet, aquatic exercise, manual lymphatic drainage, and a number of antioxidant supplements that we've been recommending for years, diazomin, quercetin, pycnogenol, flavonoids, rudicides, and butcher broom. And they actually had really good results, so I recommend looking up this paper. And it's only 5 people, but it's a really good sign that you can do things even before you have surgery to reduce your inflammation and reduce non-lipedema tissue. And I really do believe that surgical treatment should not be performed in the inflammatory phase of the disease, and this group feels the exact same way. So you can also do what many of you are already doing, the compression garments, intermittent pneumatic compression devices or pumps, exercise of any kind, healthy eating, and the use of medications and supplements with your healthcare provider. And surgery can reduce inflammation in lipedema tissue, but again, make sure to reduce any inflammation prior to surgery. Otherwise, you're adding on insult to injury. And some people may have overactive immune systems that may make surgery difficult, and that includes mast cell activation disease. So my concluding remarks, lipedema tissue has leaky microvessels. This is, I think this is now firm. This has been shown in multiple studies. This is a real thing. And hypermobile joint syndrome and possibly inflammatory vein disease or hypertensive vein disease may contribute to lipedema leakiness through those post-capillary venules. And mast cell activation disease may also contribute through the generation of histamine. And hypoxia and inflammation in lipedema tissue is chronic. So controlling inflammation is paramount in the treatment of lipedema. And just finally, that concept of microchimerism, which I hope generated some or will generate discussion, might be important in lipedema. And what does that mean? It doesn't mean we should not have children in pregnancy. It means let's get control of lipedema early. Thank you so much, and happy Lipedema Awareness Month.
Thank you very much, Dr. Herbst, for this amazing presentation. Thank you very much. We have a lot of questions, but I think that we can give the word to Dr. Wright and then move to the question. Thank you, Dr. Wright.
Well, thank you for having me, and I really appreciate this. And what a wonderful talk. I have to echo, what a wonderful talk for Dr. Herbst gave us. I learned so much from her, and it just is so, I mean, just really, really interesting and novel thinking. So I'm going to go ahead. Let me see if I do I have the right screen up. I'm going to put it in presentation mode here. And are you guys? Can you guys see me? Okay. All right. I'm just gonna. I'm gonna try and minimize this so I can see. You guys. All right. So I'm just gonna assume that you can see me okay. All right. So here we go. So I'm also talking to, for Lipedema Awareness Month. I'm going to talk about several issues that I'm passionate about. And some of this is supported by is my research that was supported by Tactile Medical. So let's see here. I'm having a little issue here. What's that? Okay. Yeah. Okay. So compression and so compression garments and intermittent compression pumps in lipedema is what I'm first. So Atan found that complete decongestive therapy with wraps and compression leads to significant decrease in limb size, and also the intermittent compression pumps decrease limb size. And then also found exercise plus the CDT and IPC led to decreased pain, improvement in social functioning, fatigue, and other health measures. And then I'm also going to share. I'm basically going to share that I've replicated some of those things and added a little bit to it. So this is data from my study showing that there was significant decrease just from intermittent compression pump in size in limb size. With losing is at the calf, losing over around a centimeter, and then and when it's and then the next slide showing this is looking at all different areas, the decrease in circumference. So in dark blue is just with compression, off the shelf compression garments, primarily either a combination of layered compression like a knee high and a capri, or compression pantyhose. And so you're seeing just the compression is leading to a significant decrease in ankle, calf, knee, thigh, and hip and waist. The compression pumps caused further decrease in all of the regions except at the hip. They actually increased in adding the compression pumps actually caused an increase in size at the hip. And so this is from Atan, and he also saw decreases in limb volume. The middle line, the group 2 is with the complete decongestive therapy, but even just exercise and even exercise plus compression, exercise plus compression pump also led to decreased limb size in both left and right limbs. And he showed all these things, the pump, the exercise, and the compression wraps all decreased the pain the lipedema ladies experienced. So now I'm going to talk a little bit about extracellular water. And So extracellular water is composed of plasma, interstitial water, and lymph. So now the plasma volume is very tightly regulated and really doesn't change. So when I'm going to show the changes in extracellular water, it's really just changes we're seeing in lymph and interstitial water. So the same in the same patients, same lipedema ladies, they had the compression plus the pump, or to the compression alone, led to decrease in extracellular water, or measured. We're really measuring here the extracellular water to total water and ratio, and so that led to so this is really important because there's we know the European consensus said that there's no edema. So in lipedema, but if you're seeing a decreased, so even just immediately applying the compression pump, you're seeing a decrease in the limb size, and immediately you're seeing a decrease in extracellular water. I mean, obviously that's fat doesn't change that quickly. It's got the water change is there. There has to be edema in this, and it's obviously either in the lymph or in the lymph compartment, or more likely also lymph and interstitial compartments. Okay, so now I want to talk a little bit about the biology of lipedema fat. So, I mean, everybody listening here has probably already noticed lipedema tissue grows out of proportion, or persists even when with weight loss, or increases out of proportion to the rest of the body. I mean, that's really one of the hallmarks of lipedema. And so what we already know is this adipose tissue is different. We can look at it if you take it out surgically. When I operate, I look at this fat. It looks different than non-lipedema fat. It's more nodular, it's more fibrous, and this is just a picture of it. And so even before we look at it under a microscope, we know it's different. But when we this study is by Ishak and was published last year, and shows that there's different tissue signaling going on in the lipedema tissue, and these differences in terms of their gene expressions, the cellular components, metabolic products, and propensity for proliferation. So and we're going to go into maybe there's a candidate gene that might be involved, and so this is really this, as we go through this evidence, I want to try and convince you that the lipedema fat tissue is different from the obesity fat tissue. So this is so on the right here is a picture of the heat map. So this is mRNA gene expression, and you can see blue is decreased expression, gene expression, and the red is increased. And these are z-scores, or magnitudes of difference in each color gradation. So the lipedema tissue here in the first 50 genes is decreased, in compared to non-lipedema, those are increased, and then another set of genes, the lipedema fat, is increased, and the non-lipedema fat. So there's quite quite a difference in what genes are turned on and what are turned off. And then if you look at the lipedema fat cells, they're gonna be different in terms of even their composition. So they're gonna have different phospholipids. So glycerophospholipids and sphingolipids are going to be different. They're going to have different compositions or different relative amounts. So up here, and these are just, I mean, it's not really important exactly which of these phospholipids are increased in expression in lipedema and versus non-lipedema, or decreased in expression. But you can see here, there's just, if you plot out what the lipid composition of these cells are, they're very different. And so now looking next at stem cells, and these, you know, this graph over here, CD29 and CD34 positives, that is what they used as a marker for stem cells. And you can see here that the lipedema tissue had a dramatically increased number of stem cells in it compared to non-lipedema. And just a quick reminder, stem cells are cells that can continuously divide and renew themselves. So they can become other either supportive tissue or mature fat cells. So they can go different, and they can perpetually renew themselves. So if a stem cell is going to become a fat cell, it's going to get fat droplets in it, and so. And as it matures to become a fat cell, it's more and more fat droplets are going to occur, and so there's not only more stem cells, but more of them are on their way to even in the stem cells that you select from lipedema versus non-lipedema, they're on their way to becoming fat cells, a greater proportion of them. And that's just, you know, so each of the stem cells has more fat droplets, compare in the lipedema versus the non-lipedema. And now, they also looked at cell cycle genes, and there's as you can see on the right, there's a variety of there's 7 or 8 cell cycle genes, and they're all upregulated. These are obviously in the lipedema fat, and these are obviously the genes that are responsible for division and proliferation of the tissue. And one of them they focused on was the BUB1 gene. And BUB1 gene, I mean, because it's involved in other diseases, they gave that some special interest. But we don't know. No one knows exactly. It could be any of these, but the important things are that if you're looking at the genes from stem cells from lipedema tissue, they're turned on, and those cells will proliferate even in response, even when they're given the same nutrition. They're gonna proliferate in the culture wells compared to non-lipedema fat. So the adipocytes and their stem cells from lipedema fat are structurally different and behave differently. If given the same nutritional support, they're going to proliferate. And so there's a different cell biology of lipedema, and this leads to hyperproliferation of fatty tissue and may explain the disproportionate growth in the adipose tissue of lipedema. And so, but we still don't know. So this biology, I think, is really well demonstrated, but we don't know if that's because of a genetic difference, or is it a bad cell, or does it live in a bad neighborhood? And so that still remains to be seen. So I'm going to talk a little bit about surgical treatment of lipedema, and there's multiple things surgical treatments for lipedema, but most of it's going to really on what I call lipedema reduction surgery, or what we like to call lipedema reduction surgery, which is a derivative of liposuction. But there's also skin reduction, removal, and manual extraction of lipedema nodules. So when to consider surgery? I have to echo what Karen said. Surgical treatment should really be considered only after conservative measures, including compression use, diet, and weight loss, have been done. You've gotten your inflammation under control. You've gotten it under control by supporting your lymphatics, by diet, by manual lymph drainage, and possibly intermittent compression pumps. So who's a good candidate? Well, obviously, lipedema patients. Lipedema is a fat disorder, and lipedema ladies, even a very healthy lipedema lady, is going to have an increased BMI compared to someone without lipedema. So we have to we're more liberal in how large a lady we might do surgery on. But once you get to really larger BMIs of 50, or the proportion of them that have, just from their weight, have a secondary lymphedema. So 90% of women with BMIs of 50 are going to have a secondary lymphedema just as a result of their comorbid obesity or their weight. Dr. Herbst is very strong proponent of waist to hip ratio, because that's a better measure for a lipedema lady than BMI of their overall relative health and fat mass. So we might be more liberal if they have waist to hip ratio less than 1. And they should be compliant with a diet and either weight neutral or having weight loss before the surgery. Compliance with compression, because it makes no sense so if you do surgery, you're gonna make the swelling worse, at least for a short period of time, and you have to have good compliance with compression and overall fair to good health. Obviously, some health. This is medically necessary, so it's not. You don't have to be in excellent health, because sometimes just the lipedema can impair your health. So, there's. We want a good health is recommended. So liposuction is a cosmetic procedure. It's one of the most common cosmetic procedures, and it's focused on optimal removal of fat for aesthetic results. And derivatives of liposuction are increasingly used for surgical treatments of lymphedema and lipedema. So I'm going to talk a little more about that. So lipedema reduction surgery is not liposuction. Obviously, it's not. The goal is not a cosmetic improvement. The goal is to focus on pain relief, functional improvement. It removes larger volumes. It is not. I mean, I regularly remove 5 to 12 liters of aspirate, whereas in a cosmetic liposuction, I might, 1, 2, maybe 3 liters of aspirate is removed. It's performed on larger patients. Obviously, the average BMI of my lipedema patients is about 42, whereas a cosmetic patient, where BMI is around 25. Larger areas are treated, so we're also often treating, 4 or 5 what would be considered cosmetic surgical areas in one lipedema reduction surgery. They're longer procedures. The average total procedure time is around 4 to 6 hours, and then there's measures to protect lymphatics. We're going to get into that a little more. So we're not just extracting fat. We're obviously fibrous tissue and extracellular glycosaminoglycans are also targeted. The benefits of lipedema reduction. So these have been shown in multiple case studies. It improves gait and stance, reduces pain, reduces need for compression and MLD, and can reduce the stage or halt progression. This has really all been. I mean, I have to thank my European colleagues for this. These are all things that have been shown by my colleagues in Europe. I also have been following and trying to add to our knowledge about what kind of health effects lipedema reduction surgery can do. And so we used RAND SF36 it's a patient-reported outcome using multiple domains of health. And then also the PROMISE, which is an NIH, National Institute of Health, developed tool that for patient-reported outcomes and such as mobility. And then these measures are used in a wide variety of diseases, and can kind of, so we can kind of compare the effectiveness of lipedema reduction surgery to other treatment of other diseases with surgery. So this is we see here that there's starting out before surgery, the physical functioning of our lipedema patients is below the mean population, and after surgery, measured about 6 to 8 weeks out, have come to normal. So that's a 1 or 2 standard deviation improvement. The role and physical functioning also improves. Role of energy and fatigue, significantly improved. Social functioning and pain improved. Overall general health improved and crossed the midline. This is the same kind of data, though, just graphed out, and you can kind of see that there's on all the health domains there's an improvement. And this is similar. These kind of changes in health in these health domains, can be compared to the effects for people with chronic back pain and having back surgery. So chronic back pain also suppresses their physical function, role function, and the improvements we see from the lipedema reduction surgery are actually as good, or on some domains quite a bit better than the improvements seen from treating chronic back pain with back surgery. So now looking at the PROMIS data, we can see, we're seeing a 15% increase in ability to walk at normal speed, an 18% increase in ability to go up and down stairs, ability to get up from the floor without help, ability to run a short distance, and ability to stand for an hour. And all those changes are significant. So comparing using the PROMIS data, which is also used on many different diseases and treatments, we can see that the lipedema reduction surgery improves. So this is a normalized value, so goes up 10 points, which is over a standard deviation. And what is these changes are so a 2 to 3 point change is considered minimally clinically important change in healthcare, and that's so for comparison, a total knee replacement for someone who has end stage degeneration of their knee and gets a replaced knee gets a 3 point to a 5 point improvement using the same PROMIS measures. We also see improvements in knee range of motion. So this picture here shows how we measure the knee flexion or range of motion and flexion of a knee. And then we also see an improvement in valgus rotation and decrease in Q angle, improvement in gait in 84% of the patients. So, lipedema reduction surgery and lymphatic reductions. We know that lipedema patients have impaired lymphatic function, and extra care should be taken. So there's a lot. So it's really variable. Some surgeons don't take any extra precautions, and some do. I do all of these precautions. I preoperatively map venous and lymphatic structures. I use small cannulas, only blunt cannulas. I don't use additional energy. I use longitudinal techniques in multiple positions. So they pretty much the type of this lipedema reduction surgery, they're rotating around 360 degrees so they're all every different angle and position they're held in to get the optimal placement of the cannulas. So this is sort of a cautionary tale. This is a patient that presented to me. She had lipedema, and she had developed after her surgery some swelling in her right foot, and this is her lymphocitogram, and I actually think I reversed the anterior and posterior, but you can see here that the right foot or on the right the radioactive colloid does not go up, so there's impaired lymph flow at 30, 75, and 90 minutes, and there also shows some mild dermal backflow, whereas the left leg is more normal, and you can see even within 30 minutes the uptake is already to the groin and where it should be, and so even at 90 minutes in the right leg, it has not gone up into those lymph nodes. Insurance coverage for lipedema. So many policies are contradictory. It's really while there are policies that cover it, the reimbursement for it is all over the place. It's very variable, highly inconsistent. One of the problems is it's coded with a cosmetic procedure code in the U.S. We have because it's a cosmetic. So the policies use a cosmetic code, which I think is wrong, and should be it should have its own CPT code. There's really no official, because the official, all the official procedures that for insurance and medical disease are go through what our AMA and health department creates an official description. Well, that doesn't exist for the cosmetic code that our insurance carriers in the United States assign to this, and so it doesn't describe the time, skill, risk involved. Doesn't really. I mean, so you can get a cosmetic liposuction, which is 1 or 2 hours, and maybe removes a liter or two, and is a much simpler and there's less risk involved. There's a huge they can say that's, the carrier, our insurance carriers can decide whatever they want to pay for that, and so it's very it's very problematic at this point. Of course, we hope it gets better. I think I put some more slides in here, but I'm not going to do them because I wasn't sure whether Dr. Herbst, I wasn't sure how much time I was going to do, and so I'm gonna stop here and turn it back over to our hosts.
Thank you very much. Super nice presentation, super interesting. Thank you very much.
Thank you. Thank you, and thank you for including us in this lipedema awareness. We really, this is so wonderful.
I think what you have just covered is quite overwhelming to take it all in, but it's wonderful how it's been backed up by so many facts and studies, because I think this is key, isn't it, Valeria, to pooling this knowledge of information, because sometimes a new study comes up, and I know even just looking after our website, it's hard to keep up with the latest one, and sometimes interpret a very detailed study to know what steps forward we've made through that study. So I think you've both done a brilliant job of explaining some very technical stuff to us. I think we've had quite a few questions come in, Valeria, haven't we? Do you want to kick off with the first one? Yeah.
Yes. Just one thing. In the chat of our socials and YouTube, you will find the link to the survey Dr. Herbst prepared. So would you please fill in? I'm sorry, we have also another problem in the chat. So if you see some inappropriate messages, it's not us. We are being hacked. So we do apologize for this, and for the next webinar, we will manage to solve this. So we are sharing all the link to the questionnaire in all the socials, and we will make stories on Instagram about this. So please fill in this questionnaire. And for the questions, we have plenty, but I see that a very big hot topic is hypermobility. I'm reading a question coming from Lipedema UK, a patient from Lipedema UK that is asking about the relationship between hypermobility and Ehlers-Danlos syndrome and lipedema. She asks how much of this laxicity of cells and junctions in lipedema could be attributed to the comorbidity of hypermobility of Ehlers-Danlos, or is lipedema itself?
That's a really great question. So nobody knows the answer to that, but it could be that if you have a connective tissue disease, including Ehlers-Danlos, that can definitely weaken the connections between cells and contribute to the leakiness. Absolutely. But in the paper that we looked at today, what they did was they took normal, quote unquote, normal, so non-lipedema endothelial cells, and they took fluid from lipedema cells and put it onto the normal cells. And the normal cells began to leak. So it may be that there's something else that's going on in lipedema besides a connective tissue disease. So I think when I'm thinking about a connective tissue disease, I think that it actually can cause a worsening of lipedema. It can cause lipedema to advance to a higher stage, or it can cause a greater amount of pain, or it can cause a greater amount of disability. But, you know, again, we're still in early stages. This is just, you know, we're just talking here. There's no final proof for what I just said.
Could I ask a very basic question, which probably is, I don't know if it's inappropriate or not, but when children do gymnastics when they're young and girls are very flexible, if you suspect that there is lipedema in the family or mothers are concerned about it, is that a best to avoid situation, or is it nothing to worry about? You know, if people are going to be stretching their joints, and I mean, I have grandchildren who are just doing gymnastics all over the place. So, you know, is it a little bit of a danger area for them to go into when they're young, sort of before puberty, or would you have no concerns about that?
Well, I mean, I remember when I was a young girl and we would be outside and we would do the craziest things, you know? So basically it seems to me like what we're saying is kids that have hypermobile joints shouldn't be doing anything really. You know, they should be sitting inside or playing, you know, which I don't think there's good data for that. What I think there is good data for is that if you have, for example, hypermobile joints and your ankles, you know, your ankles just doop to the side, you know, you walk and whoop, and then you stand right back up and you keep going. You go, I'm fine. Whereas somebody else, if their ankle went like that, it would have sprained horribly.
Oh yeah.
So I don't want to restrict girls with hypermobile joints or with a risk for lipedema from playing and doing all the things that they should do, because I think the more they exercise as kids, the better. The more they sit in front of a computer, the worse. So at this point, I don't think we can say that. Although it might be good if you have a gymnastics instructor to say, you know, go up to them and say, hey, by the way, my daughter she has hypermobile joints. I just wanted to make you aware, you know, can you keep an eye on her? Because some things that, you know, some things you shouldn't do for hypermobile joints. And, you know, there's physical therapy books out for EDS. But again, how many people are going to be like professionals who know EDS really, really well?
Okay.
So
Something on good research. Yeah.
We need more research. We really do.
Thank you.
Thank you.
Yeah.
Yes, do we have other questions from? I have actually an interesting one. Let me read it, because it's the question of the century, because it's asking, is there any evidence concerning the difference between normal adipose cells and lipedema fat cells? So how can we distinguish this lipedema fat from normal fat? What are the latest evidences for this? It's something that our patients often ask us, and we do not provide the answer because we do not know it.
Yeah. I mean, there's clearly biological differences in the fat cells of lipedema and in the tissue and all the surrounding tissue. So I think we have to say there clearly is a difference in that, for sure. It's not fully understood, all the differences, but there are enough that we have to say that it's different.
Okay, but there
I
is
would agree with that. I think that on the molecular level, it's become clear that you can differentiate between lipedema tissue and non-lipedema tissue and many different parameters. So if we age and body mass index match controls to lipedema, and then we take their tissue, you can absolutely tell a difference in the amount of immune cells that are in the tissue, the type of lipids that are in the tissue, as Dr. Wright showed, the ability to form new fat cells, the secretion of fat cell hormones. So it is definitely different. But clinically, when you look at a woman with lipedema, you cannot say, oh, here's a little area, or it's very difficult to say, here's an area that is not lipedema, here's an area that is lipedema. And we know from the lymphedema world that in a single arm, so in an arm, let's say this arm has lipedema, there are going to be areas where you have lymphedema and areas where you do not. So it's kind of mixed in there. And we think the same thing happens with lipedema. If you take a woman with lipedema and you put her on a keto diet and she responds really well, she can lose fat from her legs, right? There's fat that's responsive to diet in the legs of some women with lipedema. I will not say all. And that means that there's a mixture of some lipedema and non-lipedema tissue there. But we really don't have an image modality that can differentiate between them. Even ultrasound, you can't. You can tell, yes, it's lipedema, it looks like lipedema, or it doesn't, but you can't say, oh, here's an area and here's one that's not. And it's very difficult.
I would just add, so I would add exactly, I agree completely with Karen, but I would add also, like, on physical exam, I mean, we look for like a nodularity or in the area, but there's lipedema in that area, but on just by touching or looking at someone, you can't tell which cells are going to have lipedema. Those are only you can only tell that by if you look at the gene expression or under a microscope or something like that. So,
right, I have a question about histamine and antihistamines. Would you recommend in any way taking antihistamines as a routine medicine for somebody who has lipedema?
The only women I would recommend antihistamines for are in women who have signs and symptoms of excess histamine. So there's a really good paper by Dr. Larry Afrin published in 2016, and his I'll pull it up, maybe I could share it, but his first table shows a lot of the signs and symptoms of mast cell activation disease. And if you can go, there's also a questionnaire available online where you can go through and you can answer a whole bunch of questions to see if you have what looks like mast cell activation disease. And in those patients, I would consider it. And what Dr. Afrin recommends is that you actually get tested first. Because you want to know if you really have it. Otherwise, you're looking at lifelong antihistamine treatment when you may not really need it. And then secondly, if you really have mast cells that are over-responsive, they may actually be over-responsive to another ingredient in the antihistamine. So when you take it, you feel worse. And you say, oh, this didn't make me better. This made me worse. But really, if you're working with somebody who knows mast cell disease, they can recommend a different antihistamine and then a different one and then a different one until you find one that actually works for you. So
and who would you go to help you through that process other than the questionnaire you mentioned? Because again, this is a very complicated thing for your
very complicated
get through the healthcare provider.
So you would want to go to an allergist or allergy immunology specialist who has an interest in mast cells. Some allergists don't care.
Okay, that's very helpful. So if you really think that's an avenue that would help you,
yes. So if you do think allergy. If you do think you need antihistamines, absolutely, it could help you, but you definitely need to work with someone.
Okay, that's really helpful.
Super. And I have a question actually that is not kindly medical, but some advocates in the introductory questionnaire asked your opinion about the issue of renaming lipedema. You know, there is a group of scientific people that is proposing a change in the name of our disease. So what's your point of view in the renaming lipedema issue? Do you agree or not? I'm asking Ruth.
Yeah, I think we are making such great strides right now in understanding lipedema that why are we renaming it right now? Let's just wait a little bit longer so that we can really understand the pathophysiology. Like, I doubt any of the, I should go look, but I just don't think it, right now I'm not ready to rename it. First of all, part of the renaming process was because they don't believe that there is edema and lipedema. And one of the papers that, since I focused on inflammation today, I didn't focus on edema, but Shelley Krasinski from Vanderbilt University just came out with a paper using magnetic resonance imaging, or MRI, to find fluid in the tissue. And she found that in 75% of women with lipedema, you can see interstitial edema. And that's what we've been saying is present all along. There were also some women, especially those with lipolymphedema, who had diffuse edema, suggesting that, you know, there's free fluid and interstitial bound fluid. So I do think there's edema and lipedema. So why are you renaming it? Because it's lipedema. And then secondly, we're getting so close to the pathophysiology. Let's figure it out and then rename it for what it really is, rather than renaming it now and then naming it again.
Yeah, that seems sensible to me.
So maybe what we could do is we could say lipedema, also known in Germany as blah, 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 blah. And that's probably what I think we're going to do. And not, you know, it just depends on what the name ends up to be. And it is painful. And I know they want to include something about pain in the name. And I think that's appropriate. And hopefully they'll keep the lipo part. But we'll see.
Okay.
I would also, I'd like to add in there. I mean, I think actually it's as apt a name as we can find. I mean, every name change is going to have some downsides, but it is a lipomatosis, so it's lip, and it's not edema. So I mean, and I think, you know, I mean, I mean, not every lady with lipedema, you know, in the original studies had pain. So I don't think right now there is a better name than lipedema.
Okay. So I had a comment from a healthcare professional in the UK who was very interested in your suggestion to checking fatty livers, if people have a fatty liver. So again, that's something for people to maybe mention. Again, where would they go to for that if you don't have a really good clinician who's up in lipedema?
Yeah, so at least here in the US, primary care providers can order an ultrasound of the abdomen. And they just have to order the right side of the abdomen. So it's a very inexpensive, very quick, non-invasive exam. So any primary care provider should be able to do it. And I think you need to find some pathology of the liver before you would refer them to a specialist. Like, if you don't even know if there's anything wrong with the liver, I don't think that patient would even get accepted by a gastroenterologist. So what you could, I mean, basically, what a patient can say to their provider is, I have a lot of fat on my abdomen. I have a lot of lipedema tissue. Lipedema is an inflammatory condition, and so is obesity. I'm really worried that I have fatty liver.
Okay, so that's another one to investigate. Yeah.
And I think if you say, I'm very concerned, if I have a fatty liver, then I may have insulin resistance. This may make my lipedema worse. Can you help me? Can you just ultrasound my liver?
Okay. Yeah, that's another
Isn't
one.
that the standard of care for evaluating the liver is a right upper quadrant ultrasound? Yes, it is. And even, let me just say this though, even thin people or thin looking people can have fatty liver. This is not, fatty liver is not restricted just to people who have excess adipose tissue. So if you are concerned in any way that you may have metabolic disease of any kind or prediabetes, I would not hesitate to ask for that right upper quadrant ultrasound of the liver because it is an inexpensive exam.
Okay, thank you.
So I think we have just a few minutes for the last two questions, the very last two. This is interesting because one person is asking, what about the impact of contraception on lipedema, especially the combined pill or the mini pill in young women?
So I can tell you this just right off the bat, that Lupron or injected, long-acting progesterone can actually make a woman with lipedema worse, because it actually creates inflammation. So I would say Lupron is probably not the best choice unless you absolutely have to, and that's between you and your healthcare provider. It is likely that contraception can make lipedema worse, but we have no data at all, And the question is, if you take a contraceptive pill that has high levels of hormones versus a contraceptive pill that has low levels of hormones, what's going to be the difference there? And what I've seen in my practice is when women go on contraception, they gain a little weight. And then they stay stable for a long period of time. And then when they go off the contraception, they gain a little weight. And it's not a huge amount, but it is, any weight is, no one likes to gain weight. Gain fat on their body. So I think while you're on the contraception, as long as you are stable and on the lowest dose you can, I don't think there's a lot of issue. It's just going on and coming off. So anytime you change your hormones in your body, that's when your body wants to change things up and put on weight. But there may be women out there who gain a ton of weight when they go on contraception. We're all different. We don't know. And there are people who are doing research on estrogen now and lipedema. So hopefully within the next year or two, we'll know a little bit more and can answer that question better for you.
Thanks.
That's encouraging. That's good news.
Jerry, do you want to ask the last question? Very last.
Well, I'm just very concerned about the time. I don't quite know how we're going to.
Yes.
Again, the questions about MRIs, and I think all the information you've given us, and the wonderful thing is this has been recorded, so people can go over your slides over and over again and really absorb which information is best for them and how they can use it. And as you say, the more information that comes out, the more we can have that wonderfully explained to us, the better it will be. Yeah, and healthcare providers. I think those are all my questions, actually, Valeria, given the time we have.
Yes. And just let me spend just a few words to thank you for the huge gift you gave us today, to spending your time together with us, with other healthcare professionals, with we patient advocates, and with all the patients that are listening to you. So thank you very much for staying with us and for this amazing gift to all of us. Thank you.
We thank you most sincerely.
Thank you so much. We really appreciate all you do for the lipedema community, both of you. I know you work so hard. As you know, we talk a lot, and I've never seen two people work harder in my life. So thank you so very much. Happy Lipedema Awareness Month to everyone, and thank you for everyone from hanging on and staying, and for those who watch in the future. I hope you enjoyed.
Thank you, Karen.
Thank you.
I think actually you beat us hollow in the work ethics. You're everywhere. That's great.
Thank you.
Thank you. Thank you very much.
It's an honor and a pleasure. Thank you.
Yeah, really, really helpful.
Thank you both for staying with us. Let's do our
Everybody.
because working together we can make a change. Thank
Yes.
you.
Thank you.
Thank you very much.
Thank you, everybody. Thank you for coming to this.
Bye.
And please
Thank
share
you.
all this information. Thank you.
Bye bye.
Bye-bye, everybody.